So recently we had the opportunity to have a conversation with Dr. Rachael Dirksen. And a little bit about Dr. Dirksen, she is a proud Loras Dewhawk, where she studied biochemistry and English literature. She received the Senior Biochemistry Award and was the outstanding student in biochemistry during her education there. After a year serving as an AmeriCorps volunteer, she got her MD from the University of Iowa. She was inducted into the Alpha Omega Alpha Honor Society as well as the Gold Humanism Honor Society. Double threat. She completed her primary care track internal medicine residency at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. After residency, she joined the general internal medicine primary care group at the University of Iowa, where she was a clinical assistant professor until 2020. She got her TEACH certification in 2014 from the Society of General Internal Medicine and taught residents and students throughout her time at the university. In 2021, she left the university to start her own direct primary care practice called Remedy Internal Medicine in Iowa City.
And we are so excited to have her with us today.
Yeah, you'll definitely hear that she is a personal friend of ours and also our hero and a trailblazer. Yeah. So this is the closest. We try not to fly too close to the sun with a lot of these trailblazers because
we'll get burned.
We're not worthy.
Yeah.
And Rachael is the one that we probably bother the most.
Oh, for sure.
She gave us her number.
Well, and
it's a bad idea.
When we mentioned this a little bit, but I mean, she is our go-to for all women's health questions.
Yep.
So our menopause question, she has a great answer for.
Yeah.
And her growth story is really gross.
Top flight. Yeah, it was a good one. Okay, well, enjoy our conversation with Dr. Rachael Dirksen.
Hey, Katie.
Hey, Katie.
Welcome to Heroic Herstories, Women in Medicine with the Katies. This podcast is to document the stories of women trailblazers in medicine in the state of Iowa. We're going to highlight seasoned women in medicine to create a brief oral history of their works and lives. We want to learn from their experiences, share their vast knowledge, and gain insight into the challenges they have faced. Our goal is to lift up those who have gone ahead of us and thank them for their incredible service and dedication in our wonderful field.
So today we're welcoming Dr. Rachael Dirksen. Dr. Dirksen and I joined the faculty at Iowa at the same time back in 2012, and we were partners and shared an office. Katie and Rachael and I are also commonly confused for each other by students, faculty, and residents for nearly a decade. And that really bonded us, I think. And we've stayed friends since Rachael left the university to start her own direct primary care practice in 2020. Is it okay if we call you Rachael?
Of course.
Or do you prefer Dr. Dirksen?
No, I prefer Rachael.
We want to start at the beginning. And we were wondering if we could have you tell our listeners a story about you deciding to go into medicine and what kind of pushed you towards medicine as a career.
Yeah, I was reluctant to come to medicine. I didn't really know very many people who were in the field of medicine. And I went to college thinking I was going to be a dentist. I had enjoyed my orthodontist experience, oddly enough. I know, right?
What?
I know. I was like, I don't know. I liked teeth. I was like, I think I could do this. And so it seemed good. And then I went through 3 years of undergrad, pre-health, doing all the things. And then I shadowed a dentist and they were using all these mirrors and they were drilling. And I was like, oh no, this is not what I should do. I just didn't, I shouldn't use mirrors. I shouldn't do any of that stuff. And so I can't even parallel park my car. I can't, it's just not good. And so,
especially mirrors and drills.
Exactly.
At the same time, no less.
Yes. Yeah. So I was like, I got to do something different. And so it was really stressful. I had this moment where I was like, okay, what am I going to do with my life? And I felt like I was already basically to my senior year of college and started looking around and thinking about different things. I had done some research. So I thought about grad school. I took the GRE and then I had done research things over the summers and winter breaks, and it was just not enough people. I liked the science, but it wasn't as much communication as I had hoped to do. And so I started looking at the health professions, and I even started doing some shadowing my senior year. And I applied for PA school, or was in the process of applying for PA school. And I asked my English professor, who was one of my advisors at the time, to write a letter of recommendation for me. And she said no. And I burst into tears. And and I was like, but why? And she was like, because you should go to medical school. Like, you should do this. Like, why are you? And I was like, but that seems hard and long. And it's just so much work. And she was like, I know, but like, you could do it and you should. And so I started to think about that. And I really, like, during my shadowing experiences, thought about that, because my worry was like, how do you do this? Like, how do you have a family? How do you be a mom? Like, how do you do this when you're a doctor? And it was really like, I had some good conversations. I actually shadowed an orthopedic surgeon in Dubuque who had like 6 kids, and she was an amazing orthopedic surgeon too. And so I was like, how do you do this? Like, and so it was just fun to see how other physicians were making it work. And I sort of reluctantly came around to the idea that maybe I could do it too. And so that felt like, okay, like, this gives me the science and it gives me the like service to people. And that's sort of how I fell into medicine, honestly.
I think first off, we might need the name of that orthopedic surgeon so that we can interview her as well. We can
I
get
know.
those details at the end. Sounds
Yeah.
amazing. But Rachel, when I was like looking through your CV, I mean, you're a baller, shot caller. I mean, you're like the STEM queen. Like, I was looking at like your college, like organic or outstanding student of the year in organic chemistry, outstanding student of the year in quantitative analysis. And so you just answered, a little bit of like why more the medical school part of thing, and kind of going on that humanistic route. We also saw that you are a published author in the Examined Life journal, and I wanted to hear a little bit about that experience.
Yeah. So my undergrad, I obviously, because I like the sciences, like I majored in biochemistry, but I just missed reading and writing so much that I also took a lot of English classes. And that's when my English professor, the one who told me I had to go to medical school, was like, you could just also double major in English and still get to do all these things. And I was like, oh, that sounds good, because then I could like not feel bad about reading like in my free time. It's like I'm doing my homework. And so I've always loved that. I love people's stories. I think you guys know that too. Like, you just like, sometimes I'm with a patient and I should probably be talking about more medicine, and I'm like, tell me more about that hobby that you have, or like, tell me more about this, because I just think people are so interesting. So I've always loved stories and kind of like, I don't know, getting wrapped up in them. And so through medical school and residency, part of what I would sometimes do to reflect would be to like write. And I enjoy writing poetry. I don't do it very much anymore, honestly, but that piece that I published was after a really traumatic code experience that I had with a patient who was basically had a tracheonominate fistula. And then we didn't really recognize this at the time, but then was like expectorating horrible amounts of blood, and we were like suctioning him. And so I was like shaking the whole day after that experience. And like, I think it was like a month or 2 later, I wrote that poem, and it was just kind of like how we go through these crazy experiences in medicine. And then you just like wake up the next day and do it all over again, right? Like, there's just not much time to reflect on that.
Well, even in the same hour, you have to go see your other patients.
Yeah.
Like, the
Yeah.
clock doesn't stop.
I use Rachel's example all the time with medical students because I think it's really helpful to name that for them a little bit. Like, you're going to see your residents when you're on service go through these crazy codes or really tough family conversations. And then you're going to see them like go back to the team room and be like, okay, next patient. And I think that's like protective, right? It's like trying to protect themselves from some of that like emotional trauma. But I always tell like sort of not with any identifying information, but I always sort of tell Rachel's story because I'm like, you're the first person I ever talked to who said that out loud. Like, no, it's actually like super traumatizing to participate in a code where the patient dies and then you're expected to just go see the next patient. And that's actually insane. And it had never occurred to me in all of medical school or residency that was nuts. And it is. So I thought that was really interesting about your experience and that you turned to writing about that.
Yeah. Great way to cope, right? With everything we see every day. Yeah. Well, when I was looking through then your medical school stuff, continued to be a baller, shot caller, AOA, Gold Humanism Honor Society. And I saw then, I mean, I obviously know you, so I know that you decided to do general internal medicine and primary care. And even in medical school, you had a leaning towards primary care because you applied to primary care tracks in residency. So I'm not sure if all of our listeners, all 5 of them, know about primary care tracks, but could you expand upon that a little bit about like what a primary care track is and why you decided to apply that way?
Yeah. I mean, going through medical school, it was a lot. I think you just get thrown into so many different experiences, but I like really wanted to like hone in on like what made me happy and what seemed to not fit for me. And so I knew very early on that I was not a proceduralist or a surgeon. Like I was like sweaty in the OR and I was like, I don't think this is for me. And so I started to kind of look around. I thought about women's health and I really like women's health. But again, like, I mean, OB-GYN, you're legit a surgeon. And so I was like, that's not for me. And then I started to think about like primary care family medicine, but I also was like, oh, I mean, I like kids, but I don't like the idea of when bad things happen to children. And I didn't think that I had the heart for that. And so I started to have mentors in internal medicine, like Dr. Gwen Beck and Dr. Shauna Westerman, and just how like wonderful they are. And it seemed like they had this great almost combination of sort of like women's health and in general internal medicine, and like just were just so good with their patients and like got to follow these patients along. I mean, you guys know, like in clinic, like patients are just so grateful and like to ask you about your kids. And like at the time, I was with Dr. Westerman for like my continuity of care elective in my 4th year, where we would kind of like follow her along in the year. She was pregnant. And so going on maternity leave, and all her patients like would be like, how is she doing? Is she okay? You know what I mean? Like they have like all this, like they just like have these relationships, and that's what I thought that I wanted. You know what I mean? Like I really want those I want to grow old with my patients. I want to like have this community of patients that I take care of. And I just felt like that's really what fulfilled me about medicine. And so knowing that, I knew that I like, and you guys know, in internal medicine, sometimes it's hard to find outpatient experiences, and to make sure that a residency values those outpatient experiences. And so I specifically looked at primary care tracks and the internal medicine residencies. And so like, for example, Katie, I know Wisconsin has one, and I really enjoyed my interview there. And that was actually one of the places that I ranked. And then the University of Colorado primary care track was very attractive because it had like 10 people per class who were doing it. And I was like, wow, like look at this great class of people who are like share this interest with me and that also love primary care and would be like such a supportive environment. And so that was just so attractive to me. And I mean, it's not even like a crazy amount different, but it's like, I think it's like 1 less month of inpatient each year or something. And then you get to spend that month doing, you know, outpatient type stuff like palliative care, dermatology, or orthopedics, or, you know, some of these different things that you can use in primary care. But that honestly, just being around people who seemed like they valued it was just very attractive to me when I was looking at programs.
I love that. I would like to comment that our listeners may not realize that operating rooms are freezing cold. So when you're sweating in them, I did the same thing. So I was like, when you sweat through the scrubs, like maybe not the right place for you. So, and I also loved you talked about two specific, mentors in medical school, Dr. Beck and Dr. Westerman, who Katie and I both have gotten to work with too and absolutely adore them. I was just I was wondering, how did they mentor you and inspire you? Because as women in medicine, we want to be able to provide that support and inspiration and mentorship. And I guess, how did they do that for you? And maybe not just them but also people
Yeah.
through residency.
Yeah. Yeah. I think so much of mentorship, I think, is also just seeing these people who are happy and thriving and are really good doctors, right? Like, you're like, wow, she caught that. And that was amazing. Like, like she treated that patient and they got so much better and they just love her, right? Like being number A, just being a good doctor, like that is great mentorship. And like being able to see that was amazing. Letting me be part of some of those experiences was amazing. I also think like recognizing and answering questions that maybe I had about what their lives would look like, like what would my life look like if I did what you did, and like how do you navigate this, and like what boundaries do you have, and like how does this work for you? And so I felt like everybody was really open to those questions as mentors, which was great. And then at the University of Colorado, I had a number of great mentors there. One of them her name is Dr. Mitra Razagi, and she is an internist who actually was originally from Iraq and was trained in gynecology. And then when she came over to the United States, like trained in internal medicine, and she actually created a clinic called WISH, so Women's Integrated Services in Health. And so she found her passion in like integrating these services, and then like made that happen, created her own clinic. And she just was inspiring, honestly, to see someone who did that. And so it was just great to have role models, I think, to say like, I could do this, I could be a really good doctor, and I can have a life and a family, and I can enjoy things outside of medicine too. Like it felt like they had good boundaries.
Yeah, love that. I was curious, residency is 3 years, and I think all of us it's a very impactful, intense 3 years. And I just wanted to give you time and space for if you had any particular stories or memories from residency that you wanted to share.
Yeah. How do you even like unpack that, right? Like it's just like, so I feel like it's the only like equivalent. I don't want to say that it's like battle, but I think it's like you go through this like experience with these people, and like you guys have talked about, like sometimes they're these end of life discussions. I remember, for instance, I had this end of life discussion that my attending wanted me to lead, and this patient who had like I think it was metastatic pancreatic cancer, and her whole family was around her, and it was just sort of like her pain was uncontrollable, right? Like, and we were trying to get that under control, but she wasn't sure that she wanted to kind of embrace hospice. And so we were having that conversation, and she ended up deciding that she did want to pursue hospice, and her whole family was there and heard that. And then all of a sudden, like literally the next day, we cut her pain medicines in half, right? Because like the spiritual pain that she had of just coming to that like conclusion, it just like it lifted so much weight off of her. And like things like that you're just like, did that just happen? You know what I mean? Like, did that actually, like, just those conversations that you have with people to like walk them through a difficult time, like those types of things I think stick with me a lot too. There's so many great cases you see in residency that you're just like, I fixed that, or like that was great. And I still think about those sometimes, like that I lean on some of those things.
Yeah, I love that. Thanks for sharing.
Yeah.
So then it's a real like downshift, right, from those sorts of inpatient heavy experiences in residency to primary care, you know? And so how did you feel like your transition to practice was when you started? What surprised you about that?
Yeah, I had no idea how challenging that would be for me, actually. Like, I thought my first year out of residency was one of the harder years that I've ever done. And I think a part of it is that you just feel like the buck stops with you, you know, like you're the one making all these choices and you're the one managing these patients. And then also, I mean, you had just figured out the system in your residency, and then you came to like a new system and you were trying to figure that out too. And so I was like looking up patients at night. I called patients at night sometimes to be like, are you okay? Like, everybody okay? Just check it in. And sometimes they would even laugh at me because I don't know. I think I worried more. And I don't know. It was just really hard. It was really hard. But it was good to have like a team of really amazing like general internists to like calm me down, frankly, or talk me through cases. And like Katie White and I like shared an office, and I think we talked through so many cases, and that was just so helpful. And you kind of get to the point where you're like, oh, it's more like, yeah, like we all generally have same thoughts, but it's kind of like, what's your flavor on this? And then I started to like get a feel for that and felt a little more confident with my choices. And so after that first year, I felt like it was like a really, okay, now I have some comfort level with this now, and it felt a lot better.
Yeah, I think I agree. I was there for that. And I agree. I think it was nice. I thought, you know, we both had this group of partners that were so supportive.
Yeah.
Too. Like, you know, I remember you and I would both be like, okay, I went and talked to Jim Hageman about this.
Yes. Yeah.
And I'd be like, okay, Jim Hageman said that. So then we almost like got to learn all the knowledge each other were picking up, because we would just, it was like a group shared experience learning all that stuff in our office.
Yeah. And it was fun too, because like you were from Wisconsin, like came from Wisconsin, I came from Colorado, and we're like, did you know they do these things in GI here? Or like, did you hear they do this? And so it was kind of like fun to, I don't know, like be like, how's the system work here? How do we process this?
Mm-hmm. And so then you spent about 8 years doing that, working as part of the faculty in that group at the university. And then you decided to make that career change to primary care, which is really in a lot of ways going out on your own, you know, from that sort of group practice where you had a lot of support, and then you decided to push out on your own. What was that decision like?
Yeah, that was, I mean, that was a really hard choice. I think what I was thinking about was, you know, at the time I was like, I have 25 more years of this. And I was feeling like the system, the way that it is sort of set up to have, you know, like one patient after another, and you were like booked out 4 months, and sometimes like trying to add in patients was hard, and like flexibility was really challenging. And so I was like, it's not that I don't like what I do. I like what I do. I like my partners. It's just that I felt like the system wasn't really like working for me, and I didn't think it was working that well for my patients either. And so when I started to think about other models, like concierge felt like, oh, I don't know if I want to just like take care of like wealthier patients. And I don't know that I don't think anywhere else is necessarily better. And so when I started to hear about direct primary care, it seemed like a good fit for me, because it was like, okay, I think it's not a crazy kind of fee for patients, but at the same time, like I can spend more time with them, have a smaller panel, maybe have more flexibility. And I just felt like it was worth trying. And my husband at the time, you know, like my husband, we were talking at the time, like, okay, if I fail, okay, like then we tried it and we scratched that itch, and my daughter's Zoe will see that I tried something and I was brave. You know what I mean? Like, it's okay to maybe not always go into something expecting that you'll succeed. I hope I did. I was like, no, I'm going to succeed. But I think it's also okay to take a chance.
Yeah. How do you think your approach to patient care, like to practice, has changed since you made that transition?
Yeah. It's interesting. I always felt like I was very accountable to my patients, but I almost feel more so now. A part of that is like, if they don't think I'm doing a good job, they can leave. Like, they can stop paying me. They also can reach out to me if things aren't working that I did for them. Like, if like we tried this medicine and some side effect happens, I'm going to hear about it. You know what I mean? And so I felt like I was much more likely to like feel the pressure that I had to make good choices or have good communication with my patients. But I also think that's a good incentive to have, right? Like, it's good to incentivize good care, time with patients, better communication. Like, maybe that should push me to be a better doctor.
Yeah. And you had always been an excellent teacher, and that was a big part of, nobody joins a university practice without having an and, right? And yours was teaching. And you are an all-star teacher as well. And then you've continued to teach even after you separated from the university. Is there a teaching experience that stands out as something that's particularly meaningful or exciting to you?
Yeah, I think there's something about like medical students and residents that just like, I don't know if it's like their earnestness or just their like idealism, but they just like warm my heart. So like they just like love medicine and helping people, and I just like to see that little light, like, and I just want to keep it, because I think sometimes in medicine, like, we get bogged down by, I don't know, the money or the billing or the whatever, the documentation stuff, all that stuff. And so it's nice to see them succeed and be happy. And I like, for example, so Dr. Evelyn Ross Shapiro, who is also wonderful, was a mentee of mine through med school, and then was a mentee of mine through residency. And now she is just doing lovely and successful. And it's just like, those things are so wonderful to see. And I also just really love that, because we're in this era, like in this community of teaching, that a lot of these people who become our specialists in GI or cardiology or pulmonary or whatever, like, are also people we have taught and that we know are really good, or that we, have this good relationship with. And I think it probably comes back to relationships again. I just think that if we have a good network, and the thing that I think sometimes we're lack in medicine is trust, right? Like, so I need to trust that they're going to take good care of my patients, and I need to trust that they trust me to do the right thing in, follow up. And so I like still being involved in the teaching, because I can like see this happy, bright idealism of medical students and residents and things, and then also like get to see them flourish and go on and have those relationships with people.
I think that some of that sparkle from the learners is like their like confidence that if they just keep studying, they're going to know a right answer. Like, I feel like they just have this like excitement, like, well, eventually I will know the answer to all these things. And I'm like on the other side of that, where I'm like, no, you won't. But it's like, it keeps you young to like hear their excitement.
Yeah. I think I did one case-based learning, and they're like, the learning topic that one of them chose was the EKGs. And I was like, that's a really big topic. Like, maybe we should. And so like, she gave her presentation, and then at the end, and she's like, so like, how far along were you until you felt like you were like an expert at EKGs? And I was like, I'll let you know when it happens. Like, I
think that's part of it. Yeah, I think that's part of it, right? Like, now we know we will never know everything, and being okay with that, and we can go look into that, right?
Yeah. It's funny, Blake was talking about, Blake's my husband for the listeners, but he was talking about how like the differences in like volleyball and basketball and things like that. And he was talking about how like basketball is kind of chaos, and like it's like playing jazz, right? Because you can't predict things. And I was like, that's general medicine. It's like like playing jazz, because you're just like, you're not going to predict things. We don't have as much like, all these algorithms that's like doesn't really work with us. And it's just like, you just have to kind of get a feel for things and go.
And just go with the vibes, you know?
Yeah.
when you designed your new practice, I know that there's concierge practices versus direct primary care practices. How do you explain that difference to people?
Yeah. So typically concierge practices are practices that bill insurance. So they still do the fee for service billing, but then they also have a monthly fee for patients. And often that monthly fee is, somewhere on the order of $200 or more a month. And they the reason they could still bill Medicare and all their other insurances is because this fee is for non-covered services. In direct primary care, we do not bill any insurance. And so part of that helps keep our overhead low, right? So I don't have to have billers or coders. I don't have to negotiate rates with insurance companies. And so it's all sort of the one fee that patients pay directly to us. And so we charge $125 a month or $1,200 for the year. And that includes however many visits, phone calls, text messages, that people need. And then we do have some very low cost, cash-based labs for people through LabCorp. And so people who have high deductible plans like us, because sometimes we save them a little bit of money, honestly. I have a patient who's in his 20s who's very anxious, and he has a high deductible plan. And he said every time I would go to quick care, I would get charged $400 because he just has a high deductible plan, and he was nervous about X, Y, or Z. And so he would be going almost every month. And he's like, so this saves me a little bit of money. And so I thought I'd get more of those people, the high deductible plan people. Medicare patients, for example, it's not really that financially beneficial for them. They're still paying out of pocket. But they seem to just like the availability and the accessibility, right? I usually spend an hour and a half with my new patients, an hour with returns. And then I usually have enough flexibility in my schedule that I can get people in, usually, if not that day, the next day, or, and so it turned out, because I was, worried about how much will people contact me? And it turns out if you can see your doctor that day or the next day, people are really reasonable, and they don't call you in the middle of the night.
I mean, to a lot of us listening, hearing that you get to spend an hour and a half with new patients or an hour with returns, it's kind of shocking. And I guess how has that experience been for you, and how has it been for patients? Because I'm sure they're not used to that.
Yeah. It's, for me, it's fun because it turns out, once again, I like people's stories. And so I might do medicine for so long, and then I just get to hear about them as people. And I actually joked with one of my patients. She's in her late 80s. And I was like, I'm sorry, we should probably start talking about medicine. And she goes, Rachel, this is medicine. You talking to me about my life is important. And I was like, okay, thanks. I was like, thanks for giving me permission. But yeah, so that's been really great for me, because it's the fun part of medicine is getting to know people. At least for me, it is that. I mean, yes, solving problems, helping treat people is also fun, but I think part of that is knowing their background. And so that fun part has been great for me. And then patients are enjoying it. And then one of my patients even said, he was like, I feel less stressed because I know that you can answer all of these questions, and I don't have to be like, okay, which one gets kicked off the list? I can go through all of them with you. I don't have to triage them and say oh, well, we only have so much time, so I can only do two of these things these 5 things that I want to talk about. And so it's been fun to be able to just give that time to people.
Best and worst advice you've ever received?
Some of the best advice. There was this, my senior resident during my surgery rotation in medical school. I can't remember what I said. I said something along the lines of oh, things will get better when I'm out of medical school, or things will get better when I'm done with residency. And he was like, you just gotta enjoy the journey. This is going to be a long path. You got to figure out ways to have fun and to make time for yourself. And I have thought about that a lot, because that's so true. I think people are like, well, when I get done with medical school, I'll have more control. Oh, when I get done with residency, I'll have more control. Or when my kids are older, then it'll be better. Or when it's it's going to get hard. It apparently just keeps getting harder. I think, guys, I don't know. That's what it seems. But I think like trying to manage your time and find what things are, like what self-care things you need for yourself is important. And so that was some of the best advice that I received.
And Rachel, I wanted to thank you
Yeah.
because now I think I'm like saying the wrong thing to students because I'm always like, residency is so much better than medical school. I loved it so much better, but maybe it's, I need to say like, enjoy the moment. Yeah.
I think you do get more self-determination as you go through, but I also think it's very true. I think the thing that students think that is they're going to get less busy or that there's going to be less demands on them in terms of they're like, well, I have these exams and I'm also having to do the clerkship thing or whatever. And they think that's as busy as they're ever going to get. And that's not true. And so I think there's kind of two things of it though. Like you have so many more choices once you get even into residency, like you can kind of choose how you want to do things to a certain extent. And then when you're out, you can choose it even more. So I do think there's a little bit of self-determination that comes with it, or you're choosing how busy you want to be in some ways, but you definitely don't get less busy. And that's what I think they're like, oh, you have tons of time. And I'm like, oh, well, that I do have a ton of time.
I know that you don't, Katie White.
but maybe I should. Maybe I'm just doing it wrong as possible, I guess.
All right, so I gave you a break. I was going to say, now the worst advice.
I know, worst advice. I don't know if it's like a specific advice, but I don't know if you guys feel this, but I've been thinking about this, and I think there's this undercurrent in primary care in general that it's like, it's not enough to be like a good primary care doctor. Like you should do that and be a researcher and be a whatever and do X, Y, and Z. And so I don't know. I've been thinking about that a lot lately because even coming out of practice, like, it's like, okay, you could do all these different things. And I was like, but I don't want to do things that like detract from like taking care of my patients or like taking away my clinical time. And people would like look at me like I was a crazy person, which I kind of get in some ways. But at the same time, I was like, but maybe it's okay to just enjoy doctoring and taking care of people. So I don't know if you guys feel that way too, but I've been thinking about that a lot.
Katie and I just had that conversation last week, I think.
Oh, good.
Like thinking about like the concept of protected time.
Yeah.
Which we talk about a lot in a faculty setting. Like I have protected time for research or whatever it is. And we were talking about how you're protecting from what? From patient care.
Right.
Like what you spent 7 years training how to do. Like now you need to be protected from doing it. And it's just a funny word that I know what it means and I understand what the point is, but I do think that it is interesting how I think it just reflects, to me, it always reflects like the patient care is really messy and you can frequently feel like you have better control over your environment but patients have life is messy. And so you're really jumping in the middle of somebody's life and that can be hard and emotionally hard too. So, but I think that is a really good observation that we were just discussing.
Yeah, agree. We get to do some rapid fire. Are you ready, Rachel?
Okay, I'm ready.
Okay. Well, and we said maybe we'd ask like 5, but we kind of just want to ask as many as we want to ask. So we'll just see how this goes. Okay.
Sounds good.
Okay. All right. First one. Do you go by doctor or by Rachel with your patients and learners?
Typically by Rachel.
Interesting. Has this been your whole practice or no?
I don't know. That's a good question. In Colorado, we called all of our attendings by their first name, and it was a very casual environment. Like people wore jeans, and like we didn't dress up like that.
It was just like that at Mayo, right? Were you trained?
I still got my blazer on.
Where's your suit?
I suppose like my attendings just like went hiking in the mountains afterwards. I don't know. But with like everybody, almost everybody was by their first name. And so I like, especially the younger people, which I don't know if that was like trying to be cool vibe. I don't know. And so I just kind of got in the habit of that. And so but then I read that article about like how women are less likely to be called doctor. And then I was like, maybe I should be calling myself doctor, but then now I feel like I've gotten so out of the habit of it, but patients will say, well, what do you want me to call you? And I say, I will call you by, if you don't mind me calling you by your first name, then you can call me by my first name. And then, however, when I call you on the phone, I want you to know who I am. So I'm going to say Dr. Dirksen, because then you'll immediately know who I am, rather than be like, who's Rachel? And so that's what I tell my patients.
I love
That's
that.
good. I might steal that.
Yeah.
I'm going to take that one. Okay.
What's one thing in medicine, medical school, residency that really grosses you out? Like, is there something that is a gross out?
That is a good question. I feel like everybody has their gross out thing. I have not. I don't know.
Mine's sputum.
Is it
for me.
sputum?
Sputum.
Yeah.
I can do blood. I can do anything else but sputum.
Mine's the mouth, like these loose
Oh, the
teeth.
mouth?
Like,
That's where sputum
Ugh.
comes from.
well, thanks,
You know,
Katie. Thanks for clarifying.
I'm gonna vote that I'm not a big eyeball person. Like,
Okay.
Ooh.
I pulled this really long hair that got wrapped around somebody's eyeball, like out of their eyeball.
No.
And
Now you.
Yeah. And I was like,
How did it get wrapped around their eyeball?
I don't know.
Is that
It is not for us to know.
no? That's some nightmare fuel. Right?
All right, next one. Worst pair of scrubs or style of scrubs or dress code that you've had to wear.
I actually bought my own scrubs in residency because I did not like the pencil tight. Like, I don't know who they think fits in any of those things, but it was not me. I don't know.
It's men. Men.
Oh, men fit those. Okay, gotcha. Okay.
And often 15-year-old boys who have not hit puberty. Mm-hmm.
And then I would layer my top. So I would buy my own scrub pants, and then I would just get t-shirt and long sleeve t-shirt, and then I would layer because it was always cold or hot or something was happening. And so that's what I would do in residency.
As far as I'm concerned, you're the world's expert in women's health, which evidenced by how many times I text you per month with a women's health question. What's the most interesting thing you learned recently about helping women through menopause?
That is a good question. I think that so much is in the ether right now around menopause that everybody has interesting notions about what things fix what. And so I've been really trying to get at what exactly are your symptoms, and what are you hoping that we can treat? And so I usually, in the past, I felt like we came at it like they would tell you, I'm having hot flashes or something, and we could talk through that or whatever. But now sometimes it's not even hot flashes or night sweats. It's like I have brain fog or something, but I have nothing else. But should I take hormones, right? And so I think that's been my tip lately, is that I really need to dig into what people mean by that. And then because I don't know that I'm obviously people are having hot flashes and we need to treat with hormone replacement therapy. I'm actually very for that. But I think that people think it's a panacea of it's going to make everything better. And I just don't think that's true. And so I think making sure that we know exactly what they're going through and is really helpful, because it does seem like it's more out there now, and that everything is part of it.
Okay. Rachel, what was your favorite medical school class? And if you say biochemistry, so help me God. I don't know that we're going to be friends anymore. No offense to Dr. Peter Rubenstein, who taught both of us.
Podcast over.
It's so funny because I did an undergraduate biochem summer research fellowship, little internship at the University of Iowa, and my friend got Dr. Rubenstein, but I didn't. I got Dr. Price, and so it was just funny.
It's amazing.
I know. It was just funny when I saw him in medical school. My favorite class in medical school. I don't know, guys. I'm gonna go with case-based. Can I go with case-based learning? I feel like that was the best time, because you got to actually talk through things with your classmates and hear different interesting topics. And usually there was somebody facilitating that was interesting, even if they weren't a physician. They had really cool things to say. And so that's what I'm gonna say. I'm gonna say case-based learning.
I facilitate them now, and that's my favorite 2 hours of the week.
Yeah.
Hands down. White coat or no white coat?
Depends how cold it is.
Okay. So it's a
I know, but
layer for you.
It's a layer for me. But when I was at the university, I would wear the white coat because I had the pockets. And so then I would bring my stethoscope with my white coat. But like now in my own practice, I have a stethoscope in every room. That's my stethoscope. And so I don't have to wear it. You know, it's more like if it's cold out, I might wear it. So now it's just not really a thing.
It's very practical of you. Well, any embarrassing situation you'd like to share that you can now laugh about, like passing out in an OR, dropping a pager in a toilet, done that. Anything you'd like to share?
I did like legit almost pass out in an OR. So I was, I can't even remember what procedure it was. I was on my surgery rotation and I was standing there for hours, and not eating or drinking. And then retracting something. I think we were about like in the closing stages. And then I was like, I'm not feeling so good. And I should have said that like 10 minutes earlier is what I should have said. And then so they're like, how about you step back and sit down? And so I stepped back and they like ripped that gown off of me when I stepped back. And I legit like sweat all the way through my scrub top. And everybody looked at me like, oh my God.
Like we're gonna lose one here.
Yeah, and the OR nurse is of course so smart. Like she like shoved my head down. Like I sat down, she put my head down like between my legs, and I was just like taking deep breaths. And and then like I felt terrible because then after that they're like, "Are you okay? Are you okay?"
She's like, "I'm not cleaning up puke in this OR. I'm not
exactly." They were like, "Are you gonna pass out on this patient?
Help me."
I already know this answer, but I don't know that Katie does. What's your favorite candy?
I feel like it's changing, Katie White. I do kind of, okay, Katie White knows
I don't even know you anymore.
I know. It's just, I do have a weird love of candy corn. Like, let's be real. Like, it's I know.
It's seasonal, but it's excellent.
Seasonal.
It is not excellent. I'm sorry.
But now I feel like I've been really in a mint kick, like York peppermint patties or like junior mints. I know, right? I know.
It's very grown up of you.
Zoe and Michael think it's disgusting. They're like, I don't understand why you would do any mint. And I was like, well,
more for you.
That's
great.
Me. That's right.
Favorite hospital cafeteria item?
Oh my goodness. Okay, so at Denver Health, which is the public hospital in downtown Denver, they had these breakfast burritos and they were amazing. And so after like an overnight shift, like I would get that on the way out. And so that was delightful.
Yeah. Amazing.
That might be related to this question, but what was your strategy for staying awake on call when you were a resident? Gunning breakfast burritos?
I know, but they were never open, like when you needed to stay awake. So I don't, like our program, like the cafeteria would only open until like 6 a.m. So from like 2 a.m. to 6 a.m. there was like nada, like there was like nothing to like keep you awake. And so I unfortunately like hit up the vending machines for caffeine, like, I would have like a Diet Pepsi or something at like 3 a.m. and then try to do my notes. Cause you like did all your patient care and put all the orders in. And then at 3
we were handwriting notes when I was there.
Yes. And then at 3 a.m. you sat down to like write through your notes and then it would like drift off and you'd like fall asleep on your writing. It's terrible.
Is that ink I see on your face?
I know.
So, Rachel, we'd like to transition to, you've been so generous to give us your time on this podcast. We appreciate that. So we wanted to teach you something.
Oh, good. Excellent.
Because we want to talk about a historical woman in medicine each episode. And our first one is Elizabeth Blackburn, Dr. Elizabeth Blackburn. What do you know about her? Anything?
Wait, was she a writer or no?
Yeah, she did write.
Oh. Is Katie White pimping you right now?
I know.
feel like I'm on rounds.
I am.
Okay. I think she's a writer, but that's all I know.
Yeah. Well, she was the first woman to get a medical degree in the United States.
Oh, nice.
And so we are back in the 1840s. She graduated from Geneva Medical College back in 1849, and she was admitted there in 1847 after a unanimous vote among the male student body, 150 students. They were allowed to vote on whether she got in. and it had to be unanimous, and it was because they were doing it as a joke. But she actually showed up and completed the medical school curriculum and graduated in 1849. But she did publish the first medical article by a woman later that year. So she was writing about sort of more, communication skills and, talking about compassion in medicine and things like that. She wrote about that, and which was not felt to be a true medical article by many of her colleagues, but she still did it. She founded the New York Infirmary for Women and Children in 1857, and then she put a medical program in there. So she was then trying to pay it forward and educate more women in medicine after that. She just kept founding things. She went to London. She founded the London School of Medicine for Women in 1874. She spent some time in Europe getting some training. And after, maybe we shouldn't talk about that with your eyeball concern, but she was working with a baby who had ophthalmia neonatorum, and a little bit of like the eyeball juice squirted in her eye. And she lost eyesight in her left eye after that, which imagine like going back to work the next day after something like that happens. I'd be like, I'm good on the babies and the medical stuff. Totally. She had some tough takes that I'm not sure you would agree with. Maybe you would, but she was hardcore against vaccination. Thought that bacteria were overrated in terms of a cause of disease. And she campaigned hard against contraceptives, which I know is not your stance. But so I wanted to highlight her because she is our forebear as a United States medical graduate. And she definitely defines what we're talking about on this podcast as women who really sort of fought through some adversity in order to just get the education they were looking for, have the careers they wanted. And they cleared the way for us. So we've all had an opportunity to make it a little bit easier to get to where we want to be and to determine our careers. You have the opportunity to make the practice that you were dreaming about, which is amazing. But that's started with Elizabeth Blackburn. You're welcome for that education.
It's amazing.
Thanks for the pimping too.
Yeah, well,
but Rachel, in all seriousness, we wanted to thank you so much for spending time with us. We are honored to get to spend time with you and really document her story. And for all of our many listeners, we're so thankful you joined us today on Heroic Herstories, Women in Medicine with the Katies. You can access this on all of the platforms, so Apple, Spotify, your favorite platform, and YouTube. And we really hope that you'll join us for our next episode of Heroic Herstories. Thank you.